We begin our investigation not in the quiet halls of a hospital, nor in the sterile confines of a laboratory, but at the very dawn of a human life. We are entering a world of breathtaking speed and profound vulnerability, a world where the blueprints of existence are drafted and built in a matter of months. This is the world of infancy and childhood. And we must begin by dispelling a dangerous myth. Children are not merely little adults. Their diseases are not simply downsized versions of adult afflictions. The battles fought in these first, fragile years are unique, waged on a different scale, with different rules, and all too often with different monsters lurking in the shadows. The stakes of these early conflicts are measured in the starkest of terms, survival itself. We can find a glimmer of hope in the statistics. The infant mortality rate in the United States has fallen dramatically from a grim 20 deaths for every 1,000 live births in 1970 down to 5.8 by 2014. But this is where our investigation must sharpen its focus, for within that hopeful number lies a troubling clue, a deep and persistent disparity. For African American infants, the mortality rate remains a stark 11 deaths per 1,000 live births, more than double the rate for white American infants, which stands at 4.9. This is not random chance. It is evidence of a conspiracy of factors, biological, social, economic, that weigh more heavily on some than on others. When we widen our lens to the global stage, the picture becomes even more complex. We see nations like Slovenia with a mortality rate as low as 1.8, and others, like Afghanistan, where the rate soars to a staggering 110.6. In this global theater of survival, the United States, for all its resources, ranks a dismaying 30th among high-income nations. These numbers are not just data points, they are the first echoes of the tragedies we are here to understand. To navigate this perilous landscape, we must map out the timeline of threats, for each stage of development is prey to a different predator. The first 4 weeks, the neonatal period, are the most treacherous. This is followed by infancy, the remainder of the first year. Then come the years from 1 to 4, and finally, from 5 to 14. In those first 12 months, the leading assassins are congenital anomalous flaws in the original design, the consequences of prematurity and low birth weight, the silent thief known as sudden infant death syndrome, and the collateral damage from maternal complications. If a life can navigate this initial gauntlet and survive the first year, the odds improve dramatically. But the threats simply change their form. From age 1 through 9, the greatest killer is not disease, but the unpredictable world itself, unintentional injuries from accidents. Among the natural diseases that still stalk these years, congenital anomalies and the dark rebellion of malignant neoplasms remain formidable adversaries. And in the final stage, from 10 to 14, accidents and malignancies are joined by the shadows of suicide and homicide, a grim reminder that the world outside the body can be as dangerous as the world within. So, let us begin our inquiry. We will open the case files on the specific conditions that define this unique and vulnerable stage of life, moving from one mystery to the next, seeking to understand the culprits, their methods, and the devastating consequences of their work. Blueprints of betrayal, congenital anomalies. Our first case file takes us back to the very moment of creation, to the architectural phase of life. Here, we investigate crimes of design, failures in the fundamental blueprint of the body. We are speaking of congenital anomalies, anatomic defects present at birth. The term itself, congenital, simply means born with. It does not, we must be clear, imply a genetic cause, nor does it exclude one. It leaves open the possibility of an inside job or an external saboteur. In the United States alone, about 120,000 babies, 1 in every 33 are born with such a defect each year. But there is a chilling truth we must confront at the outset. The anomalies we see in live-born infants are, in a sense, the survivors. They represent the less catastrophic failures in embryogenesis, the ones compatible with life outside the womb. The full scope of the problem is far greater. It is estimated that a staggering 20% of all fertilized ova are so profoundly anomalous that they are blighted at the earliest stages, silent casualties of a brutal, but necessary quality control process. Others survive longer, only to be lost to spontaneous abortion. The defects we are left to investigate are those that, while significant, were not so severe as to halt the entire project of life before it could even begin. To understand these developmental crimes, we must first learn the language of the forensic pathologist to profile the distinct methods, the modus operandi of developmental failure. First, we have malformations. These are the ultimate inside job. They represent primary, intrinsic errors in morphogenesis, the process of organ formation. The blueprint itself was flawed from the very beginning. This can be the result of a single corrupted gene or a larger chromosomal error, but most often it is a complex conspiracy of multiple factors. These errors can be localized, affecting a single system like the heart, or they can be systemic, causing a cascade of coexisting defects. Next, we encounter disruptions. These are not errors in the original plan, but rather acts of secondary destruction. Here, an organ or body region was developing normally until an external force intervened and caused it to collapse. This is not a flawed blueprint, this is an active sabotage during construction. The classic example is the amniotic band. Imagine the delicate protective amniotic sac rupturing, forming fibrous strands that drift within the womb. These bands can encircle a developing limb, tightening like a garrote, compressing and strangling the tissue. This is a one-time act of violence. It is not heritable and carries no increased risk for future pregnancies. Then there are deformations. Like disruptions, these are caused by an extrinsic disturbance. But this is not a sudden act of violence, it is a slow, crushing force. Deformations arise from abnormal biomechanical pressures that warp and twist the growing fetus. The most common cause is uterine constraint. As the fetus grows rapidly in the final weeks of gestation, it can begin to outpace the growth of the uterus. The cushioning effect of the amniotic fluid diminishes, and the fetus is subjected to compression. This can be worsened by maternal factors, like a first pregnancy or a small uterus, or by fetal factors, like low amniotic fluid or the presence of multiple fetuses. The result is a normally formed structure that has been physically misshapen by its hostile environment, leading to conditions like clubfeet. Sometimes, a single one of these events can trigger a devastating chain reaction. This is what we call a sequence. It is a cascade of anomalies, a domino effect, triggered by one initiating aberration. Our most instructive case file here is the oligohydramnios sequence, also known as the Potter's sequence. The investigation begins with a single finding, oligohydramnios, a deficiency of amniotic fluid. The cause of this deficiency can vary. It could be a chronic leak from ruptured membranes, a failure of the fetal kidneys to produce urine, a major component of amniotic fluid, or poor placental function. But, regardless of the cause, the consequence is the same: fetal compression. Without the protective cushion of fluid, the fetus is squeezed by the uterine walls. This pressure leads to a classic, tragic phenotype: flattened facial features, positional defects of the hands and feet, and dislocated hips. But the most lethal consequence is unseen. The compression restricts the growth of the chest wall, leading to underdeveloped hypoplastic lungs. At birth, these lungs may be incapable of supporting life. This case demonstrates with brutal clarity how a single, localized problem can lead to a systemic, fatal collapse. Finally, we must distinguish a sequence from a malformation syndrome. A syndrome is also a constellation of congenital anomalies, but unlike a sequence, they cannot be explained by a single initiating defect. Instead, they point to a single, powerful mastermind of viral infection, perhaps, or a specific chromosomal abnormality that launches a coordinated, simultaneous attack on multiple tissues throughout the developing body. To complete our forensic vocabulary, we must define a few more key terms. Agenesis is the complete absence of an organ and its primordial tissue. Aplasia is similar, the absence of an organ, but, in this case, the primordium existed but failed to grow. Atresia describes the absence of an opening in a hollow organ, like the trachea or intestine. Hypoplasia refers to the incomplete development or decreased size of an organ due to a lack of cells, while hyperplasia is its opposite, an enlargement due to an excess of cells. When the size of individual cells is the issue, we use hypertrophy for an increase and hypotrophy for a decrease. And finally, the term dysplasia, in this context, refers not to a precancerous state, but to an abnormal organization of cells within a tissue, a breakdown in architectural order. With our terminology established, we can now turn to the list of suspects, the known causes of these anomalies. We must proceed with humility, however, as in a staggering 40 to 60% of cases, the cause remains an unsolved mystery. The known culprits fall into three major categories. First are the genetic causes. Virtually all major chromosomal syndromes, such as Down syndrome and other trisomies, are associated with congenital malformations. These typically arise as new events during the formation of sperm or egg and are not inherited. Single gene mutations can also be the sole perpetrator. For instance, holoprosencephaly, a devastating defect of the forebrain and midface, can be caused by mutations in single genes within a critical developmental pathway known as the hedgehog signaling pathway. Second are the environmental influences. These are the external saboteurs, the teratogens. Viral infections like rubella were once a major scourge, but have been largely controlled by vaccination. A host of drugs and chemicals are also on the list of suspects, though they account for less than 1% of all malformations. The infamous tranquilizer thalidomide caused a high incidence of severe limb malformations. Alcohol is another potent teratogen. Its consumption during pregnancy can lead to fetal alcohol syndrome, a devastating combination of growth restriction, facial anomalies, and psychomotor disturbances. And we must not overlook maternal disease states. Diabetes mellitus is a common and powerful metabolic teratogen. Despite advances in glucose control, the incidence of major malformations in infants of diabetic mothers remains between 6 and 10%. The mother's high blood sugar leads to high insulin levels in the fetus, resulting in excessive growth macrosomia and a higher risk of cardiac and central nervous system defects. The third and most common category is multifactorial inheritance. This is not a single culprit, but a complex conspiracy between environmental influences and two or more genes of small effect. Common defects like cleft lip and cleft palate fall into this category. This is where we find one of our greatest investigative triumphs. We discovered that the incidence of neural tube defects could be dramatically reduced by ensuring the mother has an adequate intake of folic acid around the time of conception. This is a prime example of how we can thwart a multifactorial conspiracy by neutralizing the environmental co-conspirator, even without knowing the identities of all the genetic players involved. The pathogenesis of these anomalies is a complex interplay of timing and vulnerability. Two principles are paramount. First, the timing of the insult is critical. The first 9 weeks of pregnancy are the embryonic period, when organs are being crafted from the germ cell layers. This is the time of maximum vulnerability, with a peak sensitivity between the 4th and 5th weeks. An injury in the first 3 weeks is often an all or nothing event, leading either to death and abortion or to complete recovery. But from week 3 to week 9, a teratogenic insult can cause profound structural damage. After this period, in the fetal stage, the organs are already formed and are focused on growth and maturation. The fetus is now less susceptible to major malformations, but more vulnerable to growth restriction or injury to already formed organs. The second principle reveals a deeper truth about how these tragedies unfold. The line between an environmental insult and a genetic defect is often an illusion. The features of dysmorphogenesis caused by an external teratogen can often be perfectly recapitulated by a genetic mutation in the very pathway that the teratogen targets. Consider the corn lily plant, which contains a teratogen called cyclopamine. Pregnant sheep that eat this plant give birth to lambs with cyclopia single-fused eye. We now know that cyclopamine works by inhibiting the hedgehog signaling pathway. And what do we find in some human families with holoprosencephaly and cyclopia? Inherited mutations in the genes of that very same hedgehog pathway. Or consider the anti-epileptic drug valproic acid, a known teratogen. It disrupts the function of a family of developmental genes called HOX genes. And we find that genetic mutations in HOX genes can produce congenital anomalies that mimic those seen in valproic acid embryopathy. The same is true for retinoic acid, or vitamin A. Too much of it during pregnancy is teratogenic, disrupting the transforming growth factor beta TGF-beta signaling pathway and causing cleft palate. And what happens when we genetically knock out the TGFB3 gene in mice? They uniformly develop cleft palate. The lesson here is profound. The cell does not care how its critical machinery is broken, only that it is. The environmental poison and the corrupted gene are merely two different assassins using the same vulnerable entry point to achieve the same devastating result. A race against time, prematurity, and fetal growth restriction. Our investigation now turns to a different kind of developmental crisis, one governed not by flawed blueprints but by the unforgiving nature of time. We will examine two scenarios where the delicate process of development is dangerously desynchronized from the gestational clock. The first is the early arrival, the infant thrust into the world too soon. The second is the undergrown child, starved of resources from within the womb. Prematurity, defined by a gestational age of less than 37 weeks, is the second most common cause of neonatal mortality, surpassed only by congenital anomalies. In the United States, it affects about 1 in every 10 infants. The primary risk factors for this untimely birth read like a list of structural and systemic failures. A leading cause is preterm premature rupture of membranes, or PPROM. This is a breach in the protective amniotic sac before 37 weeks, an event responsible for as many as 1/3 of all preterm deliveries. Another major culprit is intrauterine infection, a clandestine invasion that triggers inflammation and preterm labor in approximately 25% of cases. The microbial suspects are numerous: Uriplasma ureolyticum, Mycoplasma hominis, and others. Their modus operandi is molecular sabotage. Bacterial components engage with the mother's innate immune receptors, known as toll-like receptors, or TLRS. This engagement unleashes a storm of inflammatory signals, including prostaglandins, which in turn induce the powerful uterine contractions of labor. Finally, structural abnormalities of the uterus, cervix, or placenta can compromise the integrity of the womb, making a full-term pregnancy impossible. For the premature newborn, the world is a hazardous place. Its organs are immature, its systems unprepared. It faces a manifold of dangers, including a desperate struggle to breathe, a gut vulnerable to catastrophic inflammation, and a high risk of overwhelming infection. This brings us to our second scenario, fetal growth restriction, or FGR. While preterm infants are small, their weight is often appropriate for their shortened gestational age. In contrast, infants with FGR are small for gestational age. They are undergrown rather than immature. As many as 1/3 of infants weighing less than 2,500 grams are born at term but suffer from FGR. The causes of this intrauterine starvation fall into 3 categories. The most common are maternal factors. Any condition that decreases blood flow to the placenta can starve the fetus. Vascular diseases like preeclampsia and chronic hypertension are frequent underlying causes. Avoidable factors also play a significant role. Maternal narcotic abuse, alcohol intake, and heavy cigarette smoking can all restrict fetal growth. Second are fetal factors. These are intrinsic problems within the fetus that limit its growth potential, even with an adequate supply of nutrients. Chromosomal disorders, congenital anomalies, and chronic congenital infections, particularly the notorious torch group of pathogens, are prominent among these causes. When fetal factors are to blame, the growth restriction is typically symmetric, meaning all organ systems are similarly and proportionally affected. The entire body is small. Third are placental abnormalities. This is a failure in the supply line itself. Uteroplacental insufficiency can result from a host of problems: vascular anomalies, placental abruption, thrombosis, or infection. When the placenta fails, The fetus is forced into a desperate act of triage. This typically results in asymmetric growth restriction. The body, facing a limited supply of oxygen and nutrients, actively diverts its precious resources to preserve the most critical organ, the brain, at the expense of the liver, muscle, and fat. It is a biological decision to sacrifice the body to save the mind, a stark illustration of the body's priority systems under extreme duress. Let us now open the case files on two of the most devastating consequences of prematurity. Our first case is the neonatal respiratory distress syndrome, or RDS, also known by its grim pathological descriptor, hyaline membrane disease. This is the story of the desperate and often failing struggle for the first breath. The fundamental defect in RDS is pulmonary immaturity, specifically a deficiency of a critical substance called surfactant. Surfactant is a complex mixture of lipids, primarily dipomethyl phosphatidylcholine, and specialized proteins. It is produced by type Roman II alveolar cells and coats the inner surface of the alveoli, the tiny air sacs of the lung. Its function is to reduce surface tension. Without it, the alveoli collapse at the end of each exhalation, like wet balloons sticking together. At birth, the first breath of life requires immense effort to expand the fluid-filled lungs. With normal levels of surfactant, the lungs remain partially inflated, and subsequent breaths are much easier. But in an infant with RDS, there is not enough surfactant. The lungs collapse with each exhalation. Every single breath is as difficult and exhausting as the first. This leads to progressive atelectasis, a state of collapsing, stiff lungs. A vicious cycle begins. The poor ventilation leads to low oxygen hypoxemia and high carbon dioxide retention. This causes acidosis, which in turn constricts the pulmonary blood vessels, further reducing blood flow to the lungs. The hypoxemia and poor perfusion damage the delicate epithelial and endothelial cells of the alveoli, causing them to leak protein-rich, fibrin-rich fluid into the air spaces. This exudate solidifies, forming thick, glassy, eosinophilic layers that line the alveoli, the infamous hyaline membranes. These membranes act as a physical barrier to gas exchange, worsening the hypoxemia and further impairing surfactant synthesis. The cycle of collapse, injury, and suffocation accelerates. The risk of RDS is directly tied to prematurity, as surfactant production ramps up only after the 35th week of gestation. Maternal diabetes is also a major risk factor. The high blood sugar in the mother leads to high insulin levels in the fetus. This hyperinsulinemia, while promoting growth, actively suppresses surfactant synthesis, a tragic trade-off that prioritizes mass over maturation. The clinical picture is one of rapidly escalating distress. An infant may seem fine at birth, but within minutes to hours, breathing becomes labored and cyanosis appears. The chest radiograph reveals a characteristic ground glass appearance. The treatment for this condition represents one of modern medicine's great triumphs. We can now assess fetal lung maturity by analyzing amniotic fluid. If a preterm birth is unavoidable, we can administer antenatal steroids to the mother to accelerate fetal lung maturation. And most critically, we can give prophylactic doses of exogenous surfactant directly into the lungs of at-risk infants at birth. This intervention can break the vicious cycle, dramatically improving outcomes. Our second case file is necrotizing enterocolitis, or NEC, a brutal and often fatal inflammatory destruction of the gut. It is most common in premature infants, with the incidence rising as the gestational age falls. The pathogenesis remains a mystery, a perfect storm of multiple factors. Prematurity is the essential backdrop, creating a vulnerable, immature intestine. The trigger, it seems, is the introduction of enteral feeding. This suggests that the arrival of bacteria into the naive gut sets in motion a catastrophic cascade. While no single pathogen has been definitively blamed, a key molecular assassin has been identified, platelet activating factor, or PAF. In the inflamed premature gut, PAF levels are high. This mediator increases the permeability of the intestinal mucosa, by promoting the death of enterocytes and compromising the tight junctions between them. The defensive barrier of the gut breaks down. This allows gut bacteria to migrate across the wall, unleashing a vicious cycle of more inflammation, more mucosal necrosis, and further bacterial invasion, ultimately culminating in sepsis, shock, and death. The clinical signs are stark: bloody stools, a distended, tender abdomen, and circulatory collapse. An abdominal radiograph often reveals a damning piece of evidence: gas within the intestinal wall, a finding known as pneumatosis intestinalis. The involved bowel becomes distended, friablen, and gangrenous. If caught early, some cases can be managed conservatively, but many require emergency surgery to resect the dead segments of bowel. Even for those who survive, the battle is not over. The healing process can lead to fibrosis and the formation of strictures, leaving a legacy of chronic intestinal problems. The invisible siege, perinatal infections. We now turn our investigation to the womb, often imagined as a perfect sanctuary, a fortress protecting the developing life within. But this fortress is not impregnable. It is under constant siege from a world of invisible enemies. Here, we track the clandestine routes that pathogens use to breach its defenses and assault the fetus. There are two primary fronts of attack. The first is the transcervical assault, also known as an ascending infection. This is an attack from the outside world. Most bacterial infections and a few viruses, like herpes simplex Roman 2, use this route. The invasion can occur in two ways. The fetus may inhale infected amniotic fluid just before birth, or it may acquire the infection by passing through an infected birth canal during delivery. Often, the infection itself is the trigger for a preterm birth, as the resulting inflammation can lead to rupture of the amniotic sac or the release of labor-inducing prostaglandins. For the fetus infected by this route, the most common consequences are pneumonia, sepsis, and meningitis. The second, more insidious attack is the transplacental conspiracy, or hematologic infection. Here, the pathogens, most parasites, like toxoplasma, and most viruses cross the placental barrier, directly invading the fetal bloodstream. This is a poisoning of the supply lines. This infiltration can occur at any time during gestation. The clinical manifestations are highly variable, depending on the timing of the infection and the identity of the invader. Let us profile some of these agents. Parvovirus B19, the cause of a mild childhood rash known as fifth disease, becomes a specialist assassin in the fetal environment. It has a particular tropism for erythroid precursors, the cells that mature into red blood cells. The virus infects and replicates within these progenitors, causing them to undergo apoptosis. This halts red blood cell production, leading to severe anemia. This anemia can, in turn, trigger the cascade of heart failure and generalized edema that we know as hydrops fetalis. The diagnostic clue, the microscopic smoking gun, is the presence of characteristic viral inclusions within the very cells it targets in the bone marrow. Then there is the torch syndicate, a notorious group of criminals grouped together not by their identity, but by their similar calling cards. The acronym stands for toxoplasmosis, other like syphilis, rubella, cytomegalovirus, and herpes simplex virus. An infection with any of these agents during gestation can produce a similar constellation of devastating effects: fever, encephalitis, inflammation of the eye, chorioretinitis, and enlarged liver and spleen, pneumonia, and myocarditis. If the infection occurs early in gestation, it can leave a legacy of chronic sequelae, including growth retardation, intellectual disability, cataracts, and congenital heart defects. The tragic irony is that for an adult or an older child, many of these infections are mild or even asymptomatic. But in the fetus, they are catastrophic. This is because the villain is not just the microbe itself, but the context of the host. The fetal immune system is naive and inexperienced. It cannot contain the infection. The very processes of development, rapid cell division, and migration provide a perfect, fertile ground for viral replication and dissemination. The pathogen is not necessarily more virulent. The host is infinitely more vulnerable. The aftermath of these invasions is often sepsis, an overwhelming systemic infection. We can classify it based on its timing. Early onset sepsis, occurring within the first 7 days of life, is typically acquired at or shortly before birth. The most common culprit is group B streptococcus. Late onset sepsis, from 7 days to 3 months, suggests an infection with a longer latent period or one that was acquired after birth. The drowning within fetal hydrops. Our inquiry now leads us to a truly terrifying scenario, a drowning from within. The body's own fluid, meant to sustain life, becomes a fatal deluge. This is fetal hydrops, the accumulation of edema fluid in the fetus during intrauterine growth. It can range from localized fluid collections to a progressive, generalized edema known as hydrops fetalis, a condition that is usually lethal. We will investigate the 2 major conspiracies that can trigger this catastrophic imbalance. Our first case file is on immune hydrops, the classic, though now thankfully rarer, cause. This is a story of civil war, a battle sparked by blood group incompatibility between mother and fetus. The setup is specific. An Rh-negative mother is carrying an Rh-positive fetus. During the final trimester of her first pregnancy, or more commonly during childbirth itself, a small number of fetal red blood cells can cross the placenta and enter the maternal circulation. To the mother's immune system, the Rhd antigen on these fetal cells is a foreign invader. She becomes sensitized, and her immune system produces antibodies against it. This initial response generates large IgM antibodies, which are too big to cross the placenta. The first baby is therefore usually unharmed. The attack comes during a subsequent pregnancy with another Rh-positive fetus. The mother's immune system, now primed and ready, launches a swift and deadly counterattack. This time, it produces vast quantities of smaller Ig antibodies. These antibodies are small enough to cross the placenta and enter the fetal circulation. There, they coat the fetal Rh-positive red cells, marking them for destruction by the fetus's own spleen and liver. The fallout from this immunological assault is a devastating cascade. The massive destruction of red cells leads to a severe hemolytic anemia. The anemia causes profound tissue hypoxia, which injures the heart and the liver. The heart begins to fail, leading to increased hydrostatic pressure in the circulation. The damaged liver cannot produce enough plasma proteins like albumin, leading to a drop in plasma oncotic pressure. The combination of high hydrostatic pressure pushing fluid out of the vessels and low oncotic pressure failing to hold it in results in a massive, generalized edema hydrops fetalis. But there is a deadly co-conspirator in this process, bilirubin. The massive breakdown of hemoglobin from the lysed red cells produces huge amounts of unconjugated bilirubin. This lipid-soluble, toxic substance overwhelms the immature fetal liver's ability to conjugate and excrete it. It builds up in the blood and, critically, it crosses the infant's poorly developed blood-brain barrier. There, it binds to lipids in the brain, particularly in the basal ganglia, staining them a bright, toxic yellow. This causes severe, irreversible neurological damage, a condition known as kernicterus. Fortunately, this form of hydrops has become rare due to a brilliant medical intervention, the administration of Rh immune globulin Rh-Ig to Rh-negative mothers after delivery. This injection contains anti-D antibodies that find and destroy any fetal red cells in the mother's circulation before she can become sensitized, preventing the war before it can ever begin. With the decline of immune hydrops, our second case file on non-immune hydrops has become the far more common mystery. The list of potential causes is long and diverse, but they all lead to the same final, catastrophic pathway. The most common causes are cardiovascular defects. Structural malformations or arrhythmias can lead to intrauterine heart failure, triggering the same cascade of edema we saw in immune hydrops. Chromosomal anomalies, such as Turner syndrome 45, X and trisomies 21 and 18 are also frequently associated with hydrops, often because of underlying cardiac defects. In Turner syndrome, abnormal lymphatic drainage can also contribute, leading to characteristic fluid collections in the neck known as cystic hygromas. And finally, severe fetal anemia from non-immune causes can also be the trigger. In Southeast Asia, for example, homozygous alpha thalassemia is a common cause of hydrops. And as we have seen, transplacental infection with parvovirus B19 can cause a red cell aplasia so severe that it leads to hydrops. This reveals a fundamental principle. Fetal hydrops is not a disease in itself. It is the final common pathway of catastrophic systemic failure. Despite the wildly different initiating events, an antibody attack, a faulty heart valve, a chromosomal error, a viral infection, a genetic inability to produce hemoglobin, the end result is the same. The body has a limited number of ways to fail so completely. Hydrops is the physiological tipping point, the convergence of cardiac failure and a collapse in plasma oncotic pressure. When an investigator finds hydrops, it is like finding a body that has drowned. The drowning is the cause of death, but the real mystery is what or who pushed the victim into the water. The sabotaged machinery, inborn errors of metabolism. We now move from the world of structural failures and external invaders to a more insidious realm of sabotage. We are going deep inside the cell, into the intricate biochemical factories that sustain life. Here, we investigate inborn errors of metabolism, genetic disorders where a single faulty line of code in the DNA blueprint leads to a defective enzyme. The result is a breakdown in a critical metabolic assembly line, leading either to the accumulation of a potent toxin or the deficiency of a vital product. We will open the case files on 3 of the most significant of these disorders. Our first case is phenylketonuria, or PKU, a story of a poisoned mind. This is an autosomal recessive disorder caused by a severe deficiency of the enzyme phenylalanine hydroxylase, or PA. This enzyme's job is to convert the amino acid phenylalanine, which we get from protein in our diet, into another amino acid, tyrosine. In an individual with PKU, this conversion is blocked. Phenylalanine and its byproducts from minor, shunt pathways begin to accumulate in the blood and tissues. These metabolites are neurotoxic. They cross the blood-brain barrier and, if left unchecked, cause profound and irreversible intellectual disability. By 6 months of life, the damage is evident. The concomitant lack of tyrosine, a precursor for melanin, is responsible for the characteristic light color of the hair and skin. The metabolites are excreted in the urine and sweat, imparting a strong, musty odor. There is a particularly cruel twist to this story: maternal PKU. A woman with PKU who was treated with a low phenylalanine diet throughout her childhood may be clinically normal and reach childbearing age. If she discontinues the diet, her own blood phenylalanine levels will become markedly elevated. During pregnancy, this high level of phenylalanine acts as a potent teratogen. It crosses the placenta and poisons her genetically normal, heterozygous fetus, causing intellectual disability, microcephaly, and congenital heart disease. It is a chilling example of how one body's metabolic state can devastate another. The solution to PKU is one of the great triumphs of public health: newborn screening. A simple blood test in the first days of life can detect the high phenylalanine level. If a diagnosis is made, immediate institution of a diet low in phenylalanine can prevent the brain damage entirely, allowing for normal development. Our second case is galactosemia, the tale of a sweet poison. This is an autosomal recessive disorder of galactose metabolism. Lactose, the sugar in milk, is broken down into glucose and galactose. In the most common form of galactosemia, there is a total lack of the enzyme galactose-1-phosphate uridyltransferase, or GALT. Without this enzyme, galactose-1-phosphate and other metabolites, like galactitol, accumulate in tissues throughout the body, causing widespread damage. The liver, eyes, and brain bear the brunt of the assault. The liver develops fatty change, which can progress to a scarring that closely resembles the cirrhosis of alcohol abuse. In the eyes, the lens absorbs water as galactitol accumulates, causing it to swell and opacify, forming cataracts. In the brain, there is loss of nerve cells and gliosis, leading to intellectual disability. The clinical picture emerges almost immediately after birth. Within a few days of milk ingestion, the infant begins to vomit and have diarrhea, failing to thrive. Jaundice and an enlarged liver become evident within the first week. Like PKU, the key to managing galactosemia is early diagnosis through newborn screening and the complete removal of galactose and therefore milk from the diet. This can prevent the liver damage and cataracts and allow for nearly normal development. Our final and most complex case in this section is cystic fibrosis, or CF. This is the story of a suffocating secretion, the most common lethal genetic disease affecting Caucasian populations. It is the ultimate example of how a single, simple molecular defect can be amplified by complex, tissue-specific physiology into a devastating, multi-system disease. The master culprit is a mutation in a single gene on chromosome 7, the gene that codes for the cystic fibrosis transmembrane conductance regulator, or CFTR protein. To understand this rebellion, we must first understand the loyal soldier it corrupts. The CFTR protein is a complex, gated anion channel that sits in the apical membrane of epithelial cells. Its primary job is to transport chloride ions, but it is far more than a simple channel. It is a master regulator. It also controls the function of other ion channels, most importantly, the epithelial sodium channel, or ENaC, and it plays a critical role in the transport of bicarbonate ions. The genius of this disease's pathology lies in its tissue-specific effects. The same genetic defect has dramatically different consequences in different parts of the body. In the ducts of the sweat glands, CFTR job is to reabsorb chloride ions from the sweat as it passes to the skin surface. When CFTR is defective, this reabsorption fails. Chloride, and with it sodium, is trapped in the sweat, making it abnormally salty. This is the basis of the diagnostic sweat test, and the reason a mother might notice her infant's skin tastes salty. But in the epithelial lining of the airways and the gastrointestinal tract, CFTR has the opposite job. Here, its function is to actively secrete chloride ions into the lumen. When CFTR fails here, chloride is trapped inside the cell. This has a critical secondary effect. The normal inhibitory function of CFTR on the ENaC sodium channel is lost. The ENaC channel becomes hyperactive, pumping sodium out of the luminal fluid and into the cell. Water, following the laws of osmosis, follows the sodium. The result is a profound dehydration of the surface fluid layer. Furthermore, the failure of bicarbonate transport makes these secretions abnormally acidic. The outcome is a low-volume, isotonic but abnormally viscous and acidic mucus. This thick, sticky mucus is the weapon that causes nearly all the pathology in cystic fibrosis. In the lungs, it cripples the mucociliary escalator, the system of tiny hairs that is supposed to clear debris and bacteria. The airways become obstructed. The static, hypoxic mucus creates a perfect breeding ground for bacteria, especially the notorious Pseudomonas aeruginosa. These bacteria form protective biofilms, evading antibiotics and the host immune system. This leads to a vicious, self-perpetuating cycle of obstruction, chronic infection, and intense inflammation that ultimately destroys the lung architecture, leading to bronchiectasis and respiratory failure. In the pancreas, the same thick secretions plug the small ducts, preventing digestive enzymes from reaching the intestine. This leads to malabsorption of fat and protein, malnutrition, and, over time, to the complete atrophy and fibrosis of the exocrine pancreas. The clinical picture is incredibly varied because there are over 2,000 different mutations in the CFTR gene, which have been grouped into 6 classes based on their effect on the protein. Class I, Roman II, and Roman III mutations are severe, resulting in little to no functional CFTR protein at the cell surface. An individual with 2 severe mutations will have the classic, severe form of the disease with pancreatic insufficiency. But if an individual inherits at least one mild mutation class Roman 4V or VI, which allows for some residual CFTR function, they may have a less severe phenotype, often with sufficient pancreatic function. This genetic diversity explains the wide spectrum of the disease, from devastating multi-organ failure in infancy to milder, late-onset pulmonary disease in adults. The diagnosis rests on clinical findings, an elevated sweat chloride test, and is confirmed by genetic sequencing of the CFTR gene. While management has improved dramatically, extending the median life expectancy to 50 years, the ultimate goal is to correct the fundamental defect with new therapies designed to potentiate, correct, or amplify the function of the mutant CFTR protein, now offering hope for a true cure. The silent thief, sudden infant death syndrome SIDS. We now enter the territory of the ultimate cold case. A life is extinguished suddenly, silently, and without a clear cause, leaving behind only questions and a profound sense of mystery. This is sudden infant death syndrome, or SIDS. It is crucial to understand that SIDS is not a diagnosis of a specific disease. It is an admission of a mystery that remains unsolved. The official definition is strict: the sudden death of an infant under 1 year of age which remains unexplained after a thorough case investigation, including performance of a complete autopsy, examination of the death scene, and review of the clinical history. It is a diagnosis of exclusion. When a sudden and unexpected infant death occurs, an autopsy may reveal a hidden cause of viral myocarditis, an unsuspected congenital anomaly, a metabolic disorder, or tragically, evidence of abuse. These cases are classified as sudden unexpected infant death or SUID. SIDS is what remains when all of these leads have gone cold. To investigate this phantom killer, we must first build an epidemiological profile of its victims. The most chilling clue is the timing. 90% of all SIDS deaths occur in the first 6 months of life, with a sharp, tragic peak between 2 and 4 months of age. This narrow window of vulnerability is a unique characteristic of the syndrome. The death almost always occurs while the infant is asleep, usually at night, hence the pseudonyms crib death or cot death. And once again, we see the troubling specter of disparity. The rates of SUID are more than double for non-Hispanic Black and American Indian/Alaskan Native infants compared to non-Hispanic white infants, a clue that points to a complex web of environmental and socioeconomic factors. The central investigative framework for understanding SIDS is the triple risk model. This model proposes that SIDS is not caused by a single event, but by the fatal intersection of 3 overlapping factors, a perfect storm of vulnerability. First, there must be a vulnerable infant. This implies an underlying, often subtle, intrinsic defect. The most compelling hypothesis is that these infants have a delayed development of arousal and cardiorespiratory control centers within the brainstem. The medulla oblongata, and specifically its serotonergic signaling system, is critical for the body's ability to arouse or wake up in response to noxious stimuli during sleep, such as rising carbon dioxide or falling oxygen levels. A defect in this system could render an infant unable to respond to a life-threatening situation. Second, this vulnerability must coincide with a critical developmental period. This is the first 6 months of life, a time when these crucial homeostatic control systems are still maturing and are inherently unstable. Third, there must be an exogenous stressor. This is an external challenge that a normal infant could easily overcome, but that proves fatal to the vulnerable infant during this critical period. The single most important and modifiable stressor is the prone sleeping position. An infant sleeping face down can rebreathe their own exhaled air, creating a microenvironment of low oxygen hypoxia and high carbon dioxide hypercarbia. Other stressors include sleeping on a soft surface, which can also obstruct the airway, overheating, or a concurrent mild respiratory tract infection. This model reveals the likely mechanism of death in SIDS. It is a failure of a fundamental, evolutionarily ancient survival reflex, the ability to wake up when you cannot breathe properly. In any healthy person, rising CO2 and falling O2 are the most potent stimuli for arousal from sleep. It is the brain's most basic alarm system. An infant sleeping face down creates a pocket of bad air. A normal infant's brainstem screams, "Wake up, turn your head," and they do. The SIDS infant's brainstem, due to a subtle developmental lag or defect in its arousal circuitry, fails to sound the alarm. The infant simply does not wake up and quietly succumbs. The autopsy in a case of suspected SIDS is notable for what it doesn't find. There is no single, lethal lesion. The findings are subtle and nonspecific: tiny petechial hemorrhages on the surface of the thymus, pleura and epicardium, congested lungs, and perhaps some mild inflammation in the respiratory tract. Some sophisticated studies have found subtle quantitative abnormalities in the brainstem, such as hypoplasia of the arcuate nucleus, but these findings are not universal. The primary role of the autopsy, therefore, is to meticulously rule out all other possible causes of death. The Back to Sleep campaign, which educated parents to place infants on their backs to sleep, has led to a dramatic reduction in SIDS-related mortality, a public health triumph that proves that by removing the exogenous stressor, we can protect even the vulnerable infant and prevent this tragic outcome. The seeds of rebellion, tumors of infancy and childhood. Our final investigation brings us to the ultimate betrayal, the body's own cells rising up in rebellion. Cancer in infancy and childhood is a different entity from the malignancies of adult life. They are often born from the very process of development itself, a dark and distorted echo of creation. Oncogenesis, the formation of a tumor, is a hijacking of organogenesis, the formation of an organ. First, we must survey the landscape and distinguish true tumors from tumor-like lesions. A heterotopia, or choristoma, is not a tumor, but rather a small collection of microscopically normal cells, or tissues that are present in an abnormal location, a rest of pancreatic tissue in the stomach wall, for example. A hamartoma is a focal, disorganized overgrowth of cells and tissues that are native to the organ in which it occurs. The line between a hamartoma and a benign neoplasm can be blurry, but they are fundamentally malformations, not malignancies. Benign tumors, such as the common hemangioma, are far more frequent than cancers in children. The malignant tumors of childhood have a unique signature. The types of cancer are different. In adults, the most common tumors arise from epithelial tissues: skin, lung, breast, colon. In children, the most frequent cancers arise in the hematopoietic system, leukemia, the nervous system, soft tissues, bone, and kidney. The histology is also distinct. Childhood tumors tend to have a more primitive, embryonal appearance, often characterized by sheets of cells with small, round, dark nuclei. Because of this appearance, they are often collectively referred to as small, round, blue cell tumors. This primitive histology is a critical clue, pointing to their origin in developing, rather than mature, tissue. Let us open the case files on two of the most archetypal of these childhood malignancies. Our first case is neuroblastoma, a tumor of the unmatured nerve cell. This malignancy arises from the primordial neural crest cells that are destined to form the sympathetic ganglia and the adrenal medulla. It is the most common extracranial solid tumor of childhood. The central mystery of neuroblastoma is its paradoxical behavior. It can be a relentlessly aggressive and metastatic cancer, yet it also possesses a remarkable and unique capacity for spontaneous regression, especially in infants under 1 year of age. In fact, tiny in situ neuroblastomas are found at autopsy up to 40 times more frequently than clinically apparent tumors, suggesting that the vast majority of these early rebellions are silently crushed by the body's own defenses or simply mature into benign tissue. Microscopically, a classic neuroblastoma is composed of sheets of small, primitive blue cells. The key diagnostic feature is the presence of Homer-right pseudorosets, where tumor cells arrange themselves in a circle around a central space filled with a fibrillary material called neuropil, which represents primitive neuritic processes. These tumors exist on a spectrum of differentiation. At one end is the primitive neuroblastoma. With maturation, the tumor cells can begin to resemble ganglion cells, forming a ganglioneuroblastoma. At the far end of the spectrum is the fully benign ganglioneuroma, composed of mature ganglion cells and Schwann cells. The prognosis for neuroblastoma is a complex calculation based on several factors. The patient's age is critical. Children diagnosed under 18 months of age have a significantly better prognosis. The stage of the tumor is also paramount. But the single most powerful prognostic factor is a genetic one, the amplification of the MECN oncogene. MECN is a potent driver of cell growth and proliferation. In a neuroblastoma cell, the MECN gene can be copied hundreds of times, creating massive overexpression of its protein. This genetic alteration is a declaration of all-out war. Its presence immediately bumps a tumor into the high-risk category, irrespective of the patient's age or the tumor's stage, signaling a highly aggressive course with a poor prognosis. Our second case is Wilms tumor, or nephroblastoma, the malignant kidney progenitor. This is the most common primary renal tumor of childhood, and it is a malignancy born from the very process of kidney formation. The study of Wilms tumor has provided profound insights into the relationship between malformations and cancer. The risk of developing this tumor is dramatically increased in children with certain rare congenital syndromes. The Wagner syndrome consists of Wilms tumor, aniridia, absence of the iris, genitourinary anomalies, and intellectual retardation. These children have a constitutional deletion on chromosome 1113, which removes one copy of the W-tone gene. W-tone is not a classic tumor suppressor. Its primary job is to act as a master transcription factor guiding normal kidney and gonad development. The deletion of one copy is the first hit. A Wilms tumor develops when the second, remaining copy of W-tone is mutated or lost. The second hit, the Denys-Drash syndrome, characterized by gonadal dysgenesis and early-onset renal failure, is also caused by germline mutations in W-tone. And the Beckwith-Wiedemann syndrome, a condition of overgrowth with large organs and an enlarged tongue, is linked to a different region on chromosome 11 at band 1115.5. This region is subject to genomic imprinting. In BWS, there is often an abnormality that leads to the overexpression of a paternally expressed growth factor gene, IDFTWO. This overexpression drives both the systemic overgrowth and the increased risk of Wilms tumor. These syndromes taught us a fundamental lesson. The genes that go wrong in childhood cancer are often the very same genes that are supposed to be orchestrating normal development. Microscopically, a Wilms tumor is a caricature of nephrogenesis. It displays a classic triphasic histology, attempting to recapitulate the different stages of kidney development. It contains a blastomal component, sheets of primitive small blue cells, an epithelial component forming abortive tubules and glomeruli, and a stromal component, fibrous or myxoid connective tissue. The precursor lesion for Wilms tumor is the nephrogenic resta persistent, focal pocket of embryonic kidney tissue that has failed to mature. These are the sleeper cells from which the malignancy arises. While the prognosis for Wilms tumor is now excellent, with cure rates around 90%, there is one histological feature that signals a much darker outcome, the presence of anaplasia. This is defined by the presence of cells with large, hyperchromatic, pleomorphic nuclei and bizarre, abnormal mitoses. Anaplasia is strongly correlated with mutations in the T53 tumor suppressor gene and confers resistance to chemotherapy. It is the single most important marker of an adverse prognosis. These tumors, born from the echoes of our own creation, represent the final and most intimate of the threats faced in these early years. They remind us that the intricate, beautiful process of development is a high-wire act, and a single misstep can lead to a rebellion from within. Our inquiry into the diseases of infancy and childhood is complete. We have journeyed from the flawed blueprints of congenital anomalies to the silent suffocation of a premature lung, from the immunological civil war of hydrops fetalis to the quiet mystery of SIDS, and finally to the cellular insurrections that are the cancers of childhood. In our next transmission, we will leave this world of nascent life and enter the realm of the environment to investigate the diseases caused by physical and chemical injury and the complex pathologies of nutritional deficiency.